Morning, everyone. I see everybody this morning. Dr. Chabra's out of town today. He sends his regrets. He asked that I give a few brief words here of introduction to our visiting professor. We're very excited today to have Dr. Doug Padgett visiting us from the Hospital for Special Surgery. Dr. Padgett is currently the Surgeon-in-Chief and Medical Director at HSS, as well as the Corin Wilson Professor and Chair of Orthopedic Surgery at Weill Cornell Medical College. He went to St. Michael's College and the New York Medical College after that, before he completed his orthopedic residency at HSS. He did a one-year fellowship at Rush in Chicago. He then went to the Naval Hospital in San Diego, where he was Director of Joint Replacement for 3 years before returning to HSS. When he returned to HSS, he took over as Chief of Orthopedics at the Bronx VA, and subsequently became the Chief of Adult Reconstruction and Joint Replacement at HSS until 2019, whereupon he assumed the role of Associate Surgeon-in-Chief. Doug has really been very influential in adult reconstruction. He's served on just about every board. He's involved in every society, certainly on the board of AAHKS, Hip Society. He's received numerous awards, research awards from multiple groups. Widely recognized, internationally recognized, really as an expert in hip and knee arthroplasty. Continues to be very busy clinically, despite taking over the major role of Surgeon-in-Chief at HSS this past fall. So a true honor to have Dr. Padgett here. Before I turn over the mic to Dr. Padgett, I just wanted to share a brief story about Dr. Padgett and how I got to know Dr. Padgett. When I finished my fellowship 14 years ago, I had taken my job here. Dr. Abel, who's the chair at the time, talked to me about doing hip arthroscopy. We didn't have any hip arthroscopists here. This is before Dr. Gwathmey. And he said, we really need somebody to do hip arthroscopy at UVA. Would you be willing to do that? And I said, sure, I'd be happy to do that, but I don't know how to do hip arthroscopy. I'm going to have to learn somehow. And we set up a 10-day observership with Dr. Brian Kelly at HSS. And so I finished my fellowship. I went right from Rochester, Minnesota to New York to hang out with Brian and try to learn hip arthroscopy in 10 days. First day I'm there, I show up, I go to conference, I see Dr. Padgett. Dr. Padgett comes over, introduced himself, said, "Who are you?" I said, "I'm James Brown. I'm here to learn hip arthroscopy." And he looked at me kind of funny and he said, I'll never forget, he said, "Why are you doing that?" He said, I said, "Well, I got to do it as part of my job. I'm going to be a hip arthroscopist." He goes, "You don't want to do that. Come on with me. Come on with me." So I went with Dr. Padgett. He showed me his lab. I went into the OR with him, did a bunch of hip and knee surgery. HSS at the time was at the forefront of 3D printing. You showed me a bunch of cool models. And I think I spent as much time with you that those 10 days I did with Brian Kelly. I did see some hip arthroscopy. And would be happy to know I got here and I did 0 hip scopes at UVA. So thank you for that major influence in my career. I'll be forever indebted to you for that. So without further ado, I'm going to turn it over to Dr. Padgett. And again, Doug, thanks for coming to UVA.
Well, thanks, JB. It's certainly my pleasure to be here. I had some great stories about JB that I was going to share, and then he just reminded me that this is being recorded and will be on YouTube. So I am not going to tell any stories at this point for his longevity here at the institution. So I'm going to share a little bit of my journey over 3 decades, a little bit. I call it Life on the Back Nine. By way of background, I'm an avid golfer. I played golf my entire life. I love playing golf. It's one way to do things outside of the field of medicine, and it is a lot of fun. By way of disclosure, I do receive royalties related to hip products from DJA Global. I'm a shareholder in an organization called Provisi Surgical Innovations. I'm going to reference that a little bit in the second talk in terms of looking at opportunities working in both an academic medical center as it relates to economics. It'll come back. And I'm a board member at the hospital as well as the Journal of Arthroplasty. Special thanks to Mindy Frank. I don't think I met Mindy. I don't know if Mindy's here. Thank you, though. She handled some of the logistics. Monica, with great show for services she supplied. I really appreciate that. Got here, did not get into an accident. It was close. I'm not sure she actually saw that vehicle that we almost hit. But anyway, but she's going into sports medicine, so that's okay. And then obviously to James Brown for this kind of invitation. So I'm going to share a little bit of orthopedic history, share a bit of personal viewpoint on some orthopedic trends, and then share some personal thoughts on the surgeon industry dynamic, which I think is relevant. So life on the back nine, orthopedic life imitating golf, or is it the other way around? I'm not sure. It's one way or the other. So in golf, as in life, we often reflect on what do we learn on the front nine? Okay, so whenever you go, those that don't play golf, you break it into two halves, and at the end of the first half, you usually go to the halfway house, and if you're having a bad round, you go get either a martini or something to drink or something like that. But you start to think about what are the things that did go wrong. And I'm going to break this down into three things. Blind shots. These are things that we didn't see on the front nine. Time to consider new technology. That's great. Golfers were always changing, looking at new clubs and golf balls and things along those lines. And then finally, mulligans. I wish I could do that over again. So let me share with you my orthopedic back nine. My blind shot, that was trunnions. And we'll spend a little bit of time looking at trunnions and discussing that. That technology is robots. And I have a personal point of view on that I'd like to share with everyone here. And then finally, in terms of mulligans, that's recalls, and that is a pain in the neck. And I will also share a little bit of that, right? So these are things that I didn't see coming. And unfortunately, we continued to deal with some of them. So chapter 1 on trunnions right here. So this is the lab. This is some of the stuff that JB probably saw all those years ago. I really like to thank the main person in the lab is Dr. Tim Wright. He's the chief of biomechanics at HSS. He's been, we've had a collaboration for 25 years at this point in time. Tons of fellows and residents that have come through. I work collaboratively with the Department of Radiology as well as the Department of Pathology, looking at a lot of these things. So let's not forget that the total hip replacement is the operation of the century, not hip arthroscopy, no, hip replacement. Okay, pain relief, predictable, improvement in quality of life, predictable, and extension of longevity. It's an interesting concept, but there's a lot of data that shows that actually people after hip replacement compared to other cohorts actually live longer. Unfortunately, failures can occur. We're all aware of this. Here's the patterns of revision total hip. This is an article that Kevin Bozick wrote. It's probably on the in-training exam, probably on the board exam, using nationwide inpatient samples. They looked at the common types of revisions, and those reasons for revisions were instability, mechanical loosening, and infection. But it's important to remember that those cases that Kevin was reporting on were cases that were done in the 80s and 90s, and a lot of things have changed. We looked at our own experience over a 5-year period of time. This is because we got a grant from the federal government. So all of the patients at HSS were enrolled in this database. We had an opportunity to want to see what were they doing 5 years later. So in 2017, we looked at this and we started looking at our own internal reasons for failure at the hospital for special surgery. And it's interesting, instability came at the top, infection, but then we started to see a very interesting trend, ALTR, trunnionisis, and then this rejuvenate stem recall. And it was pretty interesting because these were all biologic failures. And the question is why? Remember, in 2000, we went to crosslink poly in theory to eliminate osteolysis and biologic failures. So 3 things basically happened during this period of time. It's always important to remember a little bit of orthopedic history, right? Because the time frame, every 20 years, something, if you want to be novel, this is to the residents and the medical students, if you want to really be on the cutting edge, get JBJS from 20 years ago, see what they were doing then, and then start doing what they were doing 20 years ago. And you're going to be at the forefront because people forget what happened 2 decades ago. So it's pretty fascinating. But 3 things happened. In order to reduce instability, we started using a lot of bigger heads, oftentimes metal. And I also want you to think a little bit about metal and metal to reduce issues related to ceramic fractures. So people were starting to look at ceramic heads and the use of that, but we used to get these burst fractures because the trunnions were somewhat robust. So what did the manufacturers do? They truncated the dimensions of the trunnion. They made it a little bit thinner. And if you think about the mechanics of what goes on in a trunnion right there, that change in the dimensions right there will affect some of the material properties and most importantly, some of the rigidity of that particular trunnion in that area right there. And then finally, number 3, we failed to appreciate the potential risk of any trunnion right there. In some ways, the FDA was really to blame if you think about it. So just going to take you a little bit back in time in an attempt to streamline the awful requirements for the introduction of new devices into clinical use in the United States, they came up with this statute. The statute was 501K. It's a big legal document. It was approved by Congress. The year was 1976. And it came up with something that was called substantial equivalence to a legally approved device. No need for pre-market authorization right here. So if it was kind of substantially equivalent to what was already approved, you could get away with it. You could introduce it into the marketplace. In 1976, and probably half the people in this audience weren't even born then, these were the two approved devices. On your left is the Charnley-Mueller stem, and on your right is the McKee-Ferrar implant. So we'll just take a look at this couple of things. Number one, they were cemented implants. And number two, they were monolithic, right? They were single piece. It's important to remember. So metal implant on the right and the original Charnley-Mueller on the left. As a consequence of that, and because of the somewhat lax rules right here, there was a new generation of lots of different stuff, including the introduction of metal-on-metal bearings. And the big thing was the big femoral head metal-on-metal total hip replacements. Large heads for stability, conceptually made sense, improved range of motion, theoretically, improved tribology, meaning metal-on-metal articulation. Think again, back early 2000s, number one issue that we were dealing with was osteolysis. And then at this point, no restrictions in terms of letting the patients do what they want. So with this, there was this explosion in terms of designs galore, as I like to call it. We had monoblock shells and modular cells. Think of the modern day dual mobility implants that we have. There were full hemispheres and subhemispheres and large heads. And then the introduction, or the reintroduction, this is version number 4 now, of hip resurfacing. In the middle of about the early new millennium right here, somewhere around 2006, 2007, concerns started to surface about metal ion elevation, especially in metal-on-metal total hip replacements, reports of something called a pseudotumor, which prior to, I don't think any of us really knew, and a description of this Al-Val condition right here. And lots of reports, a lot of them coming out of the UK, David Langton and his group. You can see, again, early failures of these metal-on-metal bearings right here. Not surprising, there was this very rapid use in metal-on-metal usage. Most simply assumed that the main culprit was, in fact, articular wear. But the key, actually, and what really turned out to be the problem, was the trunnion was probably the real culprit right here. So this brings up the concept of articular wear versus taper and trunnion wear. And we touched on it at last night's session right here. So on the left-hand side, you can see articular wear. Think metal on metal, like even a hip resurfacing right here. Oftentimes what you'll see is this concordant rise in metal levels. So cobalt and chromium will symmetrically go up. Just think of the fact that basically you're hard polishing that implant. Okay, so that makes sense. And you get some dissolution of that bearing, that cobalt chrome surface right there. The causes: surface design, component position, including effective position in terms of, and we've talked a little bit about spinal pelvic kinematics and things like that. And also this effective containment. And that was one of the deficiencies in these subhemispherical. So these are cups, not 180 degrees, but could be 150 degrees, 157 degrees. On the right-hand side, trunnion wear, and this could occur in both metal on metal as well as metal on poly. You see this discordant rise in metal levels. You'll see cobalt preferentially elevated over chromium. So you might see that ratio. You send somebody off for metal ion levels, their cobalt comes back 8, their chromium comes back 1. You need to start thinking about, well, why is that? Why is that? That could suggest that maybe there was a trunnion problem. It's not totally understood. Probably the smartest guy on this, Josh Jacobs. Still, I don't think Josh has a good explanation. Lots of theories about solubility of cobalt versus the precipitation of chromium orthophosphate that comes out. The causes are mechanically assisted crevice corrosion, loss of passivation, lots of reasons. But it's important to remember all head sizes were at risk, and a lot of people forget that and forgot that. This is typically what it would look like when you would see these greenish clumps of chromium orthophosphate. This was a revision case for someone that had trunnionitis. So what did we learn? The trunnion could be an issue. Trunnion could be an issue. So we got all excited about this because this is a great opportunity for exploration. So some brief primer here on trunnions for those not familiar. Again, original stems, we talked about 1976, that monolithic single, meaning non-modular implant. So the original stems, monolithic. So each stem size had a short, medium, and long neck version. So if you had size A, B, and C, they each had 3 versions monolithic. This required massive inventory. Okay, so it really wasn't sustainable. And it certainly wasn't practical for the manufacturers. So what was the solution? Modularity. Modular junctions give the ability to adjust lengths, offset, head size. Okay, makes sense. Results extremely successful in the reduction in inventory. So what's a trunnion? It's an interference fit consisting of a female-born and male trunnion. Thought best as a cold weld with tight tolerances. We'd like to think that it's pretty rigid, with minimal motion at the interface. All types of trunnions. Remember, it's not just hip replacements, also in total shoulder replacements and lots of different areas in orthopedics. Are they all the same? The answer is not at all. There's very unique characteristics. They have different diameters. The trunnions do. Length of engagement can vary greatly. The surface finish can vary greatly. The material of the trunnion might be titanium, titanium alloy, cobalt chrome, things like that. So this really gave us a lot of opportunity to look at all these trunnions. 1214 for the residents in the room, it's very common size. Are they all the same? In the bottom right hand, those are both 1214 tapers. They don't even look remotely similar right here. 1214 refers to the dimensions of the cone taken at two distinct areas, okay? But for different manufacturers, where they take that dimensions varies greatly. So these regions vary greatly among manufacturers, and that results, there's lots of variability in the cone angle. So just remember that just because someone has a 1214 and it's made by, I'll just throw a manufacturer, DePuy, that 1214 DePuy taper is not the same as the 1214 taper from Zimmer Biomet. So clinical introduction right here. This is an 80-year-old male. In 2006, he undergoes a right total hip replacement, an uncemented cup with a cross-link poly. So this is the new era, okay? He had a uncemented titanium alloy stem and a cobalt chrome hem. So he was part of a dislocation study that we have. You can see all those measurements that we were making at the time. He comes in for his 2-year follow-up as required by this protocol. He's doing great. Absolutely terrific. He comes back at 5 years and he feels great. And he's asked me, he says, do I need to come back anymore? And, you know, it's a busy clinic and I'm not really paying a lot of attention and stuff like that. We got some x-rays and the patient says he's doing fine. Who's going to argue with the patient, right? If he's doing fine, you know, that's great. And I probably did a cursory view of his x-ray and I told him to come back in 2 years. So a couple of thoughts right here. So here's the 1-year view and here's the 5-year view. And for those in the audience, I want you to look at the proximal medial part of the femur right there. You start to see what appears to be some loss of bone and loss of support. So if this had been performed in 1990, we'd say this is a classic case of early osteolysis. But time out, we just cured osteolysis in 2000, right? So what the heck was going on? So anyway, I didn't pick up on it. I told him, yeah, go ahead. So he comes back less than a year. He's got severe pain and inability to walk. And this is what his cup looks like, right? Okay. So this is what this case taught me. Osteolysis in the new millennium is rare. It's unusual, and it should have raised issues at the time for me personally for some biologically triggered event. Now, that could be an infection, which is one, but again, he was completely asymptomatic. But there was obviously something else that was going on right there. So trunnionitis, it saw me before I saw it. I did not recognize this, I will admit, and I was not alone. Lots of people failed to recognize this. And my concern is that it became a very popular topic at the academy and lots of meetings and stuff like that. But almost like the way of osteolysis, we don't really talk about trunnion-related problems anymore. There's a couple of reasons. Maybe some are good. Maybe it's because of the change and the migration to ceramic heads. But there's a lot of metal heads out there, I can tell you right now, and it's still brewing. Did anyone ever think this was going to be a problem? So here's some things that I knew were never going to work. So those of you that are going into sports medicine, so this sort of like hemi-cap for osteonecrosis right there, that thing that looks like a thumbtack, okay? Did anyone ever think putting a piece of metal on articular cartilage was really going to work, right? Okay, so we knew that that wasn't going to work. And I was always suspicious of these dual modular necks right here, okay? So I was pretty confident. I was really like, I never did any of these operations, thank God. But I knew when I was really suspicious that they weren't going to work. But this putting a metal head on a trunnion, I mean, come on, we've been doing this for decades right there. Did I ever think that was going to be a problem? Jeremy Gilbert, who's here, who can't keep a job, keeps moving from Northwestern to Syracuse to Clemson, this and the other thing, I say that tongue in cheek. He's like among the smartest guys. He's an engineer. He observed corrosion, 25% of the tapers, back in the day when he was working collaboratively with Josh Jacobs at Northwestern. And he wrote about this in 1993. 1993, I was just finishing my training at that point in time, and he already was warning everyone. But no one listens to an engineer, right? You know, they're dull, they're boring. Jeremy is not actually, but you know, but no one listens to engineers. They want some of them, a flamboyant orthopedic surgeon that really doesn't know anything about engineering. Say, oh, don't worry about it. It's not going to be a problem. You know, this is Robert Barrack telling Hollis, this is not going to be a problem. There's no problems with modular junctions. It appears to be more theoretical in nature. You never need to worry about this. And so what did we do? What, me worry? No big deal, right? Never affects me. Well, frankly, I think most of us just ignored it. We go ahead, we do revisions, we look at the trunnion. Okay, it's usually at this time we were like taking out loose cemented cups or something like that. So we'd see the trunnion, we take the head off. It would be black. And we take the Bovie scratch pad, right? Bovie scratch, and then we would just buff it and shine it right here. Probably the worst thing that we could ever do for the trunnion, but everyone did it. And in fact, one of our colleagues, Adolph Lombardi, came up with a very interesting device. It was almost like when you put chalk on a pool cue. He came up with this little device that you could go ahead and really, really roughen the surface and just like polish it. Again, probably the worst thing you do because you're changing the dimensions of that, cold taper right there. So anyway, as I said, we'd use the scratch pad and all that. Didn't make any sense. What really changed was about 10 years ago. So James Cooper wrote this little report, 10 patients with metal on poly, all diagnosed with quote unquote corrosion or adverse tissue reaction. And again, what was lost in the sauce, most people always just assume, well, this is a big head phenomenon. These were 36 millimeter heads. By the way, most of the heads were 28, 32s. They were not 36 right here, but everyone kind of forget about that. The clinical presentation, trunnionitis, at the time, it represented 2% of revisions. And again, I shared our data, those biologic failures in aggregate, even if we took out the recalled implant right there, was about 8% of our revisions were biologic failures. The presentation from index surgery was on a mean of about 3 years. But the symptoms were very vague and variable. Groin pain, thigh pain, lateral hip pain, okay? 2 patients with late instability, altered gait, 1 patient with recurrent hemarthrosis. And again, symptoms oftentimes very vague, often treated and misdiagnosed, and put me in that group, just as bursitis, don't worry about it. In fact, I went as far as giving a bunch of these patients that I didn't recognize injections into the hip flexor or into the bursa and all of this. They had late limp and late instability. The workup needs to be comprehensive. So when you see this, remember that infection is certainly still more prevalent than having these biologic reactions. So you need to get your SED rate and CRP. The problem is that sometimes they're mildly elevated and non-specific. Look for metal ions. I think that that's important. And aspiration. If there's a lot of metal in there, again, you need to do a manual cell count because if you send it off to the automated culture counter, it can unfortunately come back with a spuriously high elevated count. So you need to be careful about that. And this is some of the Cooper work right here, the synovial white blood cell count, mean of about 4,000. A little bit above, for those of you that are getting ready to take the in-training and the board exam, that like 2,500 to 3,500, but not like whoppingly elevated, but certainly not normal. Cultures were all negative, but they only scanned about 3 patients in this particular group. Cobalt elevation, preferentially over chromium, we talked about that. And oftentimes it took almost a year, 8 to 12 months to actually make the diagnosis. We look at a relatively small series. This is what we saw again, this disproportionate elevation of cobalt over chromium with this trunnion. Again, for us, MRI, we are from the land of MRI. We've got 18 MRI scanners at the hospital for special surgery. That's a lot. If you sneeze the wrong way, you get an MRI at HSS. And MRI was most predictive in test in suggesting this particular diagnosis. And this is what you'd see. You'd see this expansion of the synovial tissue, thickening of the synovial capsule. We went on and actually had determined that that thickening was the most predictive factor. In many instances, metal levels were near normal right here. And this was confirmed subsequently by Josh and his group at Rush, where, again, many of the patients had threshold levels of 1, which in most labs will call normal. So you need to be careful about just simply relying on that. Again, for us, cross-sectional imaging, and this is the type of image. You can see that thing that looks like a piece of cauliflower on the lateral aspect right there. It's metal suppression. The regions of interest, we're looking at synovial thickening, cystic or solid masses. And then one of the other important things and very predictive of outcome is the integrity of the abductors. If the abductors are shot, it's not good. And this is what you don't want to see. This is somebody who'd been limping around, literally limping around for a couple of years, and we failed to make this diagnosis. That's what the MRI looked like. That's what the abductors look like, that cheesy, cruddy stuff right in there. And again, very often just remember some of these metal ion levels will be somewhat normal. And just remember that modularity in these tapers, they come in lots of different forms. These are the ones that we're familiar with. As you can see on the right, that is one of the dual mobility availabilities. Let me share another story with you. This is 2-year-old male. This is a classic example of overthinking something. I will admit that. History of osteoarthritis of the right hip. I do his right hip replacement with the robot. Right, got to do the robot. Use the robot. Does well. He has 3 episodes of subluxation of this hip, which is impossible because I did the hip with the robot. So I'm not sure how that happened. I guess he didn't read the product insert. But anyway, he never wants to go through that again. That's what he tells me. Never wants to go through that because those were terrible, terrible instances. Okay, so 5 years later, he comes in. His left hip is bothering him. I said, I got the treatment for you. I'm going to use a dual mobility. This is great, okay, with the robot, by the way. Okay, so we're going to use a dual mobility implant. 1 year later, he comes in with vague lateral hip pain and groin pain. He starts limping. Of course, I make the diagnosis of trochanteric bursitis and hip flexor tendonitis. I send him to physical therapy. I think I even sent him at that point. He may have even had an injection. Do a workup after it wasn't getting better. Sed rate CRP is normal. Hip aspiration 2.2. Cultures are negative. But we get this MR. So if you look at his left hip, there's this collection of something. I don't know if this shows up with the pointer thing right here. And this is what it looks like posteriorly. And that's at the time of surgery. He's got all of these rice bodies that are there. You can literally see this. And of course, he has corrosion at the modular taper of this dual mobility implant. So am I suggesting that trunnions go away? Of course not. But I think the most important thing is that trunnionisis and taper corrosion are real. They occur in the hip. They probably can occur in the knee. They definitely can occur in the shoulder. Having an index of suspicion and prompt diagnosis is the key in treatment. And I think doing a comprehensive evaluation. And at our shop, again, a lot of it is based upon imaging. So I think it's food for thought. I've mentioned robots a couple of times. And in chapter 2, we're going to talk about new technology. A few years ago, in terms of golf, I was the worst putter at the Westchester Country Club, hands down. I was the worst putter. I would be lucky if I was on the green in regulation. That means 2 shots on a par 4. And from 8 feet, I would be lucky if I simply 3-putted. So I went to new tech. I went to the long putter. I was an early adopter and continued to use the long putter. And I'm in good company. Bernhard Langer, Adam Scott, for those of you who follow golf, they've gone to the long putter. They tried to outlaw it. That was the Tiger thing. Tiger didn't like the fact that all these guys were using a long putter. But anyway, be that as it may. So my equivalent of long putter was the robot. Now, I'm not a Luddite, okay? A person opposed to new technology of ways of working. I've been accused of that, but that's not true. So a couple of facts. I was a member of the original ZCAT team. There's probably nobody in the room who knows who ZCAT was. ZCAT was this company that was started by these 2 Carnegie Mellon grads. They were working in an industrial garage in Hollywood, Florida. And they had this concept about using a robot to help assist in orthopedic surgery. And at the time, I was interested in, I was watching people make apple cores on femoral heads arthroscopically. So I said, there's got to be a better way to do this. And for those of you who didn't know what osteochondroplasties look like in the first generation, there was some very interesting post-op x-rays that people would get. I mean, literally doing apple cores on femoral heads. I said, this would be a great technology to do this. So I actually started going down there. I got interested in that. And then I went back to my roots and said, this should probably be involved with total hip. And I was one of the first people in the world to use the robot to put in the total hip replacement. And I was among the first person in the world to stop using robotic assistance to perform total hip replacement. And I'll tell you why. So my journey on this started over 2 decades ago. The compelling issues of concern at the time were osteolysis and instability. It's 2024. So how many instructional course lectures on osteolysis did we have at the Academy this year? Any idea? Okay, I don't see any hands raised. That's right. The answer is none. Okay, we don't talk about it anymore. But 2 decades ago, we would have numerous instructional courses on how to manage polywear. Okay, it was amazing. And we just, it's gone. It's just like evaporated. Instability, on the other hand, is not. But those were the 2 issues at the time. So that's what I was facing. So we knew a lot about polywear. What we thought we knew prior to the new millennium is larger heads had more volumetric wear. And it was the large head size conundrum right here. Larger heads are more stable, but they have more volumetric wear. So there's kind of a sweet spot. And we also knew that implant position could impact wear. Now, instability, multifactorial, patient factors, implant factors, surgeon factors, all of that sort of stuff. So what holds a hip in place, if you think about it as it relates to stability? Component orientation, right? And capsular restraints, soft tissue, muscular, but capsular restraints right here. So I get some people that push back, oh, that's not true. I said, oh, really? So what's the number one complication after doing a simple liner head exchange? Instability, right? Did you change the component position? No. It's been the same way for 20 years, right? What's the only thing that you changed? You took down the soft tissues and they probably didn't heal. So that is my sort of indirect evidence for the support of that. What about position? Oh, no, not the Lewis zone. Yes, 46 years still running, the worst written paper in orthopedic history, right? So 300 patients, they had follow-up on 100. Okay, so they had 1/3, 30% follow-up right here. And it wrote this became the law of the land based on 9 dislocators out of 300, right? And by the way, half of the dislocators were in the safe zone, by the way. So if you ever read the paper, it's just like, this makes absolutely no sense. But look, you know what? We all swore about this. This was the way to go. And it became the law of the land. What we concluded was implant position was crucial to resolving lysis and instability. Okay, 2010. All right, I get, contacted by these knuckleheads down in Hollywood. Hey, you should come down here, take a look at this thing. This is about the time that JB came to New York, and I talked him out of going into hip arthroscopy. We had navigation at the time, but this concept of robotics, this novel concept of haptics, surgeon in control, creation of boundaries, was extremely intriguing to me. CT-based technology, I think you're all familiar with this, but did the original cadaveric validation work. I didn't get anything for doing this. It was actually a lot of fun working with some really smart engineers. Mike Condit, Scott Banks, who's at the University of Florida, really smart people. So we did the original validation work right here. So what I learned, the robot would deliver precisely what we thought it would: precision in preparation and precision in delivery. Were there any downsides? There's only one at the time. Cost was $1 million for a robot. It's a lot of dough, But anyway, that was the big downside. So is the robot a value add? That's the question. So let's go back to our original thesis as to why we needed the robot. Where and stability. Where? So where are we with where? I thought that was cute. I put that in there. Where are we with where? But anyway, so polyethylene millennium, complex thing. It's hydrocarbons, right? Carbons and hydrogen, stuff like cross-linked poly, you radiate it and things like that. It makes the polymer more resistant to wear. There's no question. And osteolysis has been almost eliminated. Look where we are, almost 20 years at this point in time. Look at that, where looking at this in follow-up, and these are validated studies right here, almost negligible. Observations, cross-linked polys, see less sensitive to implant position. This is some interesting data from Steve McDonald and his group from London, Ontario, Matt Teeter, who's a super smart guy. At 10 years, they could not correlate. First of all, the polymers don't wear. And by extension, regardless of implant position, and the guys in Canada definitely are not using the robot or technology to put implants in, okay? They could not make any correlation between the two. So with the modern polymer at this point, it is almost irrelevant what the implant, within reason, within reason. I mean, we've got to be realistic. So in addition to its resistance to linear and volumetric wear, the concept of minimal thickness is now defined. So what does that mean? We can use thinner polys, larger heads. So on that stability side, so far so good. So these data suggest that the introduction of cross-linked poly is responsible for improved bearing longevity, not enabling technology, not technology. So what about instability right here? We talked about this: patient factors, implant factors, surgeon factors. We talked about the Lewinick zone described in 1978, 46 years and counting right here. Okay. Socket positions, the big wild card. You could use various things. I started thinking about my own work. I was using these external alignment guides, which I still do. This was the work from Mass General. Big scatter plot here. They were trying to get that ideal 40 degrees of abduction, 20 to 25 degrees of inversion. 50% of their folks were outside. They wound up winning the Charnley Award. It talked about the problems with being outside of the safe zone right here. So we started looking at, and this again encouraged me to use the robots. We'll be in the safe zone. Everything will be safe in the safe zone. That's what the name would imply. So this is original study. So this is the first iteration, the first clinical study using the robot, 4 centers. Rich Ilgan, who's up in Wisconsin, is a colleague of mine. John Donchis down in Naples, and Bob Marchand. He and I were residents together. We looked at our first 30 cases, including the learning curve. Robots don't have learning curves, right? Okay, so there's no need for that. Okay, CT scan based, did 120. Each center was required to do 30. We analyzed 119. We were able to get all of using the Martel software. These are the results, incredibly consistent from plan, from intra-op, and from post-op right here. So the robot worked. So I looked at my own experience, almost 200 cases. I tended to use a lot of this in dysplasia, where there was socket deficiency. And I thought this was probably a good thing to do. All sockets in the civic zone, but 7 dislocations. These people also did not read the manual. They weren't supposed to dislocate. So 7 dislocations, 4 females, 3 males. Dislocation number 1 is your socket position, looks pretty good. Here's number 2, number 3. Which one dislocated? I can't remember, but anyway, one of them dislocated. So that really raised the question: was there a safe zone? Was there a safe zone? So in 2015, we looked at 7,000 hip replacements at our shop for an aggregate dislocation rate at a minimum of 1-year follow-up of 2%. And the dislocation rate was exactly the same in and out of the safe zone. Higher incidence in patients who were young, less than 50, old, older than 70, and it was definitely lower with larger heads. But that being said, there was no safe zone. Now, the data suggested at the time that led us down the path that maybe static assessment of implant position is not the way to go. So we really drank the Kool-Aid. In fact, I think we made the Kool-Aid and made other people drink it, looking at spinal pelvic kinematics. And we've published extensively on this. And this is an at-risk hip. I mean, this is not the subject of this talk, but we know that this hip is at risk, a large segment fusion at this point. Do I think spinal pelvic kinematics are being overhyped? A little bit. But I don't think you need a robot to figure out if a patient has a stiff spine. You can get some plain x-rays and do that. Or God forbid, you actually examine the patient and see what their spinal mobility is. You know, they still teach that in medical school, I think, right? How to examine patients. So I will concede the use of precision implant placement is an important feature of total hip replacement. And there is data supporting its reduction in dislocation. Rich looked at his, he had a 5% dislocation rate, which is kind of high. But you know, that's okay. And at the time of this publication, it went down to 0 using the robot. So, but he also went to bigger heads, and there's a couple of, it's multifactorial. So the current strategies to mitigate instability: larger heads, they've reduced, not eliminated, but reduced. We published on this. Maintain that offset, okay. But I just food for thought: instability. If it's not static component position, it's not functional position. And if it's not just component head size, what else could be responsible? I alluded to before. I do believe that soft tissue component right here, and I don't think we as joint replacement surgeons spent a lot of time thinking about this. I think it is going to be a little bit of the final frontier. I think a better understanding of soft tissue envelope will help our understanding of instability as well as other joints, not just the hip. So in summary, the robot does not affect long-term wear, either use or not use the robot. It's not been demonstrated directly to reduce instability, and it has no impact upon capsule laxity. Does that mean you shouldn't get a robot? I mean, I think it's a great preoperative planning tool. I think it's a lot of fun. But when you think about your value proposition, you have to take that into consideration. Is it new technology versus the latest fed? Time will tell. This is a slide. I saw the movie Oppenheimer. It kind of reminded me of Oppenheimer. I don't know if you guys saw Oppenheimer. It's a great film. That's JD in the second row there. You know, with his glasses on at a nuclear bomb watch party. Could you imagine that? Hey, I got tickets to the nuclear bomb watch party. Let's go out to Albuquerque and, you know, drive to the desert and watch them drop a bomb. Those poor people are all dead. Okay, chapter 3. We're almost there. Hang in there. Recalls. All right. This is a good friend of mine. 4 left. So every time Walt hits the ball, that's what I yell, okay? So he has a tendency, he just snaps it left, you know? He goes, let me take another swing at it. So mulligans and recall, Walt Weaver. I learned a lot from this guy. This is Larry Dorr. Larry is a very interesting character, passed away a couple of years ago. He's a terrific surgeon, innovator. He's about as funny as they come. He's a really good researcher. He was a designer, designed the APR, which had its problems. It was also known as another poor result. Some people called it that. And then when they redesigned it, it was the APR2. Some people had other names for that. He was involved, however, with this device, the Interop cementless cup made by a company called Solzer. So if you think about a hemispherical cup in hip replacement, there's not a lot of complicated requirements here. So a hemisphere, still 180 degrees, okay? You need to be able to put a poly liner in it, and it needs a porous coating, okay? So this is not, really complicated calculus, how to do this. So he started using this cup. He was one of the developers of this, who's put it in. And these are like typical radiographs that he would see. And for those of you that are not aware, these are not the types of interfaces between implant and the bone that you want to see. That's never good. So a lot of these patients had problems with loosening and all this. And so Larry sent a bunch of these to HSS, wanted to know about how much biologic fixation there was. So he sent it to our lab right here. And there was like almost no ingrowth in any of these things, not even a little bit. Inflammatory reaction adjacent to the cup in most of these. So Larry went to the guys who ran the company and said, look, you guys have a problem here. There's something that's not right. And they responded, bad technique. That's his whole Larry. And he went crazy. He went crazy, as Larry would often go crazy. And so what was going on? On the left-hand side of the screen, this is mature perversional canal development that you'd like to see in any porous implant right here. So the lamellar bone and cortical bone. And on the right, that's all fibrous tissue. That is not what you want to see from an implant that you've taken out. That is typically what you see when you've got a loose implant right in there. So the eventual findings, during the manufacturing process, there was a small amount of lubricating oil would adhere to the cup. The final step, you'd use either nitric or citric acid to passivate the shell surface, and it would remove the oil. They had a new quality control guy come in. He didn't think that was needed. So he decided to single-handedly eliminate that step in the processing right there. So with this system change, they stopped actually removing the oil. So there was a small film of oil that were on these implants that were now being sold and put into patients worldwide. Solzer eventually settled for close to $1 billion. It was acquired by Zimmer, and many, if not most of the cups were successfully revised to, I think, a more porous-friendly type thing. So this is what Larry warned me. He said, Dougie, they kept blowing smoke in my face. And so when you had a meeting with Larry, you talked to Larry, Larry would do most of the talking. You would just mostly do the listening, which was fine. And his stories were great. And it was great. So, but I thought to myself, I said, boy, I hope I never have to deal with this. I hope I never have to deal with this. So total knee replacement. We talked about total hip replacement being the operation of the century. Well, total knee's not that far behind. This is a picture of John Insel on the left and Chip Ranawat on the right, a couple of my mentors who developed the first successful total knee, or among the first successful, the total condylar knee. Was uniform in pain relief, a problem with functions, especially there. But this is the first generation right there. They developed a better understanding of kinematics and the importance of rollback. And so then became subsequent iterations, one of which was this posterior stabilized knee. It was a radical concept proposed by John Insel and Al Burstein, who was at HSS, cam post mechanism, forcing rollback to improve stair climbing, range of motion, and the like. And then there were subsequent iterations, and it continues to be on the market. The IB2, Insel Burstein 2, then next gen, which was like the third generation. The Exactech OptiTrack knee is really what we call at HSS an IB3. This is like the third iteration of the posterior stabilized knee. So our design team at HSS, and I was not involved as part of the design team, Al Burstein, who was the granddaddy of orthopedic engineering, Tim Wright, Don Bartel, those guys are engineers, and a multitude of surgeons that were surgeon designers and developers at the place. It became kind of the go-to implant for use at our place for about 20 years. Use a compression molded polyethylene. So this is a direct compression molded poly. And what it does is it aims to reduce abrasive wear and resist fatigue fracture and resist oxidation, which had plagued total knees in earlier iterations right here. So everyone agreed that this was probably the best resin, best polymer, and best way to manufacture what was going on. So let me share with you a case. This is a 60-year-old guy, BMI of 28, with severe and disabling right knee pain. and he undergoes that right knee replacement on the second slide. That's post-op, and that's him at 7 years. 7 years, and that's what his revision looked like. So it's 7 years. If you look at that, say, my goodness, what the heck happened there? So that didn't take a long time to happen. This is what his poly looked like at the time of retrieval. On the right-hand side of the screen right there, it looks like as if somebody gouged out some plastic right there. So it's called delamination. This thing is all pitted. There are all these pits in there. The poly is yellow. It just doesn't look good, right? There's something's not right here. So anyway, I do a lot of work in the retrieval lab, and Lydia, who was in the lab at the time, she shows me this, and I said, I'm sure this is an outlier. And Lydia was great. Lydia was great. She goes, oh, no, Dr. Padgett, we got a bunch of these. I said, really? She goes, oh, yeah, I got bins of these things. I said, no way. No way. She goes, yeah, this is what they look like. And in the early 1990s, when I came back, I guess the mid 1990s, I came back to special surgery. I was working at the VA, trying to build up a practice, started doing some work in the retrieval lab. And at the time, there was a clinical trial that was being done. Chit Ranawat was involved. Russ Windsor was involved. Tom Sculper was involved. And it was with a knee made by J&J. It was called the PFC knee. And they had the same problem. And there was eventually a recall of some plastics. And it had to do with some of this terminal sterilization and everything. So we had seen this before. And here it is now, almost 20 years later. And we're seeing something that looks exactly the same. So we started to determine what was the prevalence of this delamination. I'll go over some of this stuff. So, we had 400 implants. We, scored them for delamination. We did some FTIR, which is how you can determine whether they're oxidized or not. You don't want polymers oxidizing because it makes them more brittle and susceptible to this delamination. These are the reasons for revision right here. This is a time frame. This is an important slide. So if you look at the 100 implants that we looked at that were implanted prior to 2007, there are very, very few examples of delamination, but something happened in 2007. You can see all of a sudden we're starting to see these delaminations right in here. And the delamination correlated very nicely with peak oxidation. And the magic number in oxidation is that anything greater than about 2.5 to 3, that's when you really start to get worried that the polymer is going to start to rapidly fail. These are the time frames when they would occur. They range from as short as 30 months to as long as 96 months. So this is the painful part of this part of the presentation right here. So in 2018, we shared these findings and observations with company's executives. So we went to the company, we said, look, you guys got a problem. They turned around and said, bad technique. Bad technique. Exactly what Larry Dorr told me. He said, be careful, Dougie. Be careful. Really? Right. So here's an example of bad technique. Yeah, that looks awful. Yeah, that's another bad knee. Yeah, it's terrible, right? So you just had all these knees that, quite frankly, these all look good, right? Bad technique. So we looked at everything, the things that we could look at. Maybe we were using, altered cement. So we looked at cement viscosity, type of cement. We looked at insert thickness. We looked at all the patient demographics, BMI, age, whatever. Anything you could imagine, despite all our analysis. The company kept telling us, they said, no, his surgical technique was a catastrophic cause. They were put in loose inflection. The relationship between having a knee that's loose inflection and delamination, I just didn't quite understand what led to polymer oxidation. So in 2018, the company was sold for almost $800 million. And old management out, new management comes in. By 2019, 5% failure rate at our shop. It started to really decrease the usage right here because we were concerned. But a lot of people, and it's very hard, and you'll see for the younger folks in the audience, when you get used to using a system or device for a period of time, making a change is oftentimes not so easy. In December 2020, we embargoed it. I made a sort of a command decision. We no longer can use the knee anymore. We met with new leadership in 2021, and at that point, they told us that in the mid-2000s, precisely with what we learned from the retrieval analysis, it was what this non-conforming packaging was used, and it did not contain a secondary layer of ethylene alcohol, which actually vacuum sealed the implants. So what was happening is these things were getting oxidized on the shelf, unbeknownst to a lot of people. In February of 2022, they issued a voluntary recall nationwide. Recalls are a pain. I can tell you right now, I've been involved with a couple of them. This is a class 2 recall where the product might cause serious injury. There are 150,000 of these implants that were identified between the time frame that we talked about. We had 12,000 that we put in at HSS. We had to hire a third party to contact all the patients. We set up a call center. We hired a bunch of nurse practitioners and PAs to field calls and review this. These are very labor intensive interviews with patients. When patients come in, they are not happy. We set up a third party administrator to cover medical expenses and travel and the like. This is leading to a class action lawsuit. Some of the concerns that we have, does the company have financial resources? And if they don't, if they go out of business, are we on the hook for this? There's a lot of HSS reputational damage because we were part of the design team, right? The surgeons and the engineers. And the optics are terrible when you look at that. So think about front page New York Times, right? We still have a responsibility, lots of patients. Surgeon burden is very, very painful. Workup is included, multiple MRIs, CT scans, and you can ask Tracy, these are not easy revisions. These are very, very complicated revisions. We surveyed a bunch of the patients, 15% obviously expressed anger, 25% expressed concern about their own financial concern about the impact, the need for surgery, because some of these people are still working, they're out of work, they're having a revision. So why even discuss this? Okay, so I use this as an example and the role of early warning for the joint replacement folks in the world. I'm going to reference here the American Joint Replacement Registry. I think certainly it's been over, I think we waited a little bit too long to get this up and running. I think it's still evolving, but even if you go into the Joint Replacement Registry, unfortunately, this is the implant, the recalled implant right here. The failure rate as reported in the registries actually didn't pop out. It's highlighted here in yellow because I did that on the PowerPoint, right? But it didn't jump out, which is a little concerning because this is obviously, we know now in retrospect, this is a recalled implant. I do endorse and embrace the joint replacement registry, but there are some shortfalls. I think we did a fair job at HSS following our patients. But you've got to really encourage institutions to buy in terms of submission of data as it relates to the registry. Make sure you follow up with your patients and get that data transferred in. Until then, what I did was when I was going through this, I reached out to Tom Fearing because Tom was involved. He was the lead investigator with the PFC debacle from 2 decades ago. And so I think it's incumbent upon, especially the next generation of orthopedic surgeons, participate in your respective registries. I think it's important. Be observant to trends and outcomes. Share your observations with colleagues. And that's what I did with Tom. I got a lot of information from Tom. And we've shared a lot of the data as it relates to our experience with what we did, because many of our trainees left our institution and used this knee in practice. So what we did is we contacted through our alumni network, and that is really an important aspect of having these types of events, to share that information with your community, with your former residents, as well as other fellows. So a couple of parting thoughts right here. So as you enter practice, it's called practice for a reason. This is Tom Fearing. He is the king of practice. In fact, he practices so much, he practices his practice swing, which doesn't make any sense, but he does. Tells me he practices his practice swing. And then perhaps even more importantly, as you walk down the fairway of life, you must smell the roses. You only get to play one round in life. That's from Ben Hogan, arguably one of the best golfers of all time. So thanks for the opportunity to allow me to share my observations and my experience of life on the back nine. I'm not on the 18 hole yet. I may be on the, I think I'm on the 17th hole, or maybe just finishing up 16, going to 17. But anyway, so with that, I'll pause and be happy to answer any questions and take some comments.
Really fantastic talk. You touched on a lot of important contemporary topics, very honest and transparent discussions. Thank you for that. Any questions at all from the group? I have first one comment and one question. The AJR report this year did identify the off-track use not allowed. So it is showing up in AJR now. It did initially, but it is certainly off now. So that's good news. And I think speaks to the potential of the AJR. Question for you. Obviously, a blind shot wouldn't be a blind shot if you can see it coming, right? But you touched on dual mobility. You touched on some of the other newer technologies right now. What is your sense for where we may have a blind shot coming? Do you have a sense, again, would it be a blind shot coming? I get that, but where do you have concerns? I know you've got a lot of research with retrievals on dual mobility. Is that, or are there other things going on that maybe give you cause for pause?
Yes, I think on the hip side, I do have a level of concern about dual mobility. We know on the upside, there's work from the revision setting, and that's certainly very high risk people, so revision surgery, or perhaps with some mild deficiencies and things like that. There's probably I think we need to be careful about over usage. And in the end, and anyone with a hip replacement is at risk at some point for disability, for instability. Okay, but I'm not sure with the use of large heads, appropriate preoperative planning. So again, offset. Think about your femoral side. Everyone's always fixated on the socket. I would argue just pay attention to what goes on the femoral side. Look at your offset. Look at your version. Think of combined version, regardless of approach. Some people hear about the concept of combined version and say, "Oh, it's only applicable to posterior surgeons." No, it's not. It's not. Right now, there's a fair number of, we've got people that through an anterior approach still have instability. Okay. Check for commercial engagement. So I think potentially overuse of mobility, that is a potential concern. The other thing is, and I'm not sure, I think the use of enabling technology, largely in the form of robotics, as we now got into the arena of total knee replacement. I think it's exciting. What it's going to do is it's going to give us a lot of information. Okay? But I think what we need to do is we need to take that information and use it appropriately. I think we're embracing a lot of concepts in terms of capabilities and almost in blind faith, saying, "Okay, well, I have the technology at this point, and what it shows me on the screen is this is the target, this is what I need to go," and that's fine. But I think we need to validate that. I mean, I can tell you, this is not maybe the best measure, whatever. If you use, for example, if using the robot on the knee side, there's no question precision in terms of cuts and things like that. Fine. Does that mean patients have better motion, early recovery, and this and that? We looked at a small cohort, several hundred patients, and match them to robot, non-robot. Maybe not the best measure, but manipulation rates are exactly the same between the two groups. Not sure. It's a soft outcome, I get it, but it's, everyone was under the impression that use robot to put my knee in. Patients have better motion, early motion, less stiffness, and all that. And in the short term, it's not panning out.
Yeah, it amazes me too that we've had this technology now for over a decade and we have 0 RCTs.
Right.
We have no randomized trials to say there's any difference in terms of outcome. Good. Okay. Excellent. Let's move on to the next talk.
Okay.
Thank you, Doug.
All right. Okay, so this is I put this together. So by way of background, again, it's a surgeon chief and medical director at HSS. I still practice orthopedics about 50% of the time. The other 50% of the time is dealing with, I'd say, I think in a general category, call it being involved with administrative medicine. Part of it's strategic planning, part of it is operational, a lot of it's people management, which can be a problem, a challenge. But on the strategy side, I actually find that pretty interesting because healthcare is at a very interesting inflection point. By way of disclosure, HSS was a participant in the BPCI, the CJR programs, and I'm going to go over that. We have bundled packages with several Fortune 500 companies. I'm going to touch on that. We have a co-management agreement, and I am an investor with many of the surgeons at HSS as well as the hospital in a venture arm known as HS Squared, and I'll expand on that. So I'm involved with all of these things, so I can speak with this. So it's interesting. Healthcare is literally on life support. It's an interesting concept, but if you think about that, when you think about the economics, the stress of healthcare, and the outlook, it's not so favorable. So we spend a lot of time dealing with consultants. BCG is Boston Consulting Group, Mitt Romney's old firm. If you look at what's going on, just look at the main topics here. So declining revenue, okay, because of lots of different stressors, high margin procedures going from inpatient to outpatient. That has a significant impact. Ever rising expenses, especially on the personnel side. And as we've continued to expand the army of people that we employ, APPs, other physicians and things like that, lots of rising expenses, supply chain expenses as well. And then competitive threats from the outside, looking at vertical integration, companies like CVS, Amazon, they are going to be competing for the healthcare dollars. It's odd to think about that, but believe it or not, they're actually a threat to us. I'm not sure if private equity in the long run is going to stick around. I think they're starting to sense that this may not be as lucrative as it appeared to be. I mean, but anyway, just kind of food for thought. So lots of stresses on the economic side. So what I'd like to propose is a couple of options for survival. So again, this is philosophy, and I just share that with you. And I think it's done through innovation. So it's interesting, if you think about innovation, innovation is defined as a new idea, device, or method, or a novel change to an existing product, idea, or field. And it differs from an invention, which are typically products of imagination. So the best example is Alexander Graham Bell invented the telephone, right? But it was guys like Steve Jobs that came up with the concept of the cell phone. And Steve Jobs made a lot more money than Alexander Graham Bell. Right? So anyway, that's the example. So it's innovation. So think of innovation in musculoskeletal care, and they come into three buckets: devices, disease changes, or care delivery. Okay, that's how I look at it. There's maybe other ways too, but this is my own, the musings of a 60-something-year-old guy up here at the podium, right? So this is how I look at it. So we think about innovation, we think about devices. Historically, it's been the focus of surgeon inventors. So changes in implant design, changes in fixation. I alluded to it in the first talk. The most important innovation in total hip replacement the last 2 decades, crosslink poly, without a doubt. It's not a new type of a hemisphere. Okay, and it's not a new type of force coding. Okay, that is never going to change anything. Beyond this, basically what we're doing is we're building a better mousetrap. That's all we're doing right here. So I am skeptical that there is going to be a new hip or knee replacement design that is going to be just mind-boggling, despite the fact we all like to think that we're going to come up with something. In terms of disease-changing stuff, rheumatic disease, total game changer. In 1980s, I was a medical student. There would be literally dozens and dozens of people in wheelchairs at the front door of the hospital for special surgery with inflammatory arthritis. And we were doing the craziest things in the world. They treated them with very large dose steroid medication, gold therapy, all sorts of stuff, right? Crazy. What's changed? DMARDs. That's totally been a game changer right here. And they're doing a wonderful job. Small segment of the population, but wonderful job. But what's the real, I'd say, villain out there is osteoarthritis, right? So what have been the great advances in the management of osteoarthritis in the last 2 decades? And this is a quote from the recently stepped down chief of rheumatology, the Hospital for Special Surgery. Padgett, osteoarthritis is a loser. There's nothing to do about it. I mean, that was inspiring, right? It's kind of like this. Let me see, write a to-do list, forget to look at it, end up on Facebook, accomplish nothing, right? So with that level of enthusiasm for trying to conquer osteoarthritis. I'm a little skeptical that we're going to be doing a lot in terms of the medical management side. So what does it really leave us with? In my mind, it's in care delivery and process improvement. And this is where I think we probably have the greatest opportunity for impact. And I can give you lots of examples. Now, there's been a lot of historic tensions between hospitals and physicians. And this is a very appropriate talk because you're at an academic medical center. I mean, if I was asked to give grand rounds at, Adolph Lombardi's ambulatory surgery center, it'd be irrelevant because he hasn't been in a hospital in a decade. He doesn't know where a hospital is, right? But, you guys, we work in a hospital. I work in a hospital. You guys work in a hospital. But there's always been this historic tension, right? So, the administrator comes up and says, Dr. Brown, it'd be great if you could not send your 86-year-old patient to rehab after the hip replacement. And JB says, what an idiot. Why would I ever want to do that, right? And I'm sure you think that all the time, and I certainly do, right? And so why would or should surgeons and hospitals collaborate a little bit? So the hospitals are looking at things like efficiencies and market share and maintaining their margins. The physicians are concerned about patient care, but they're also concerned about money, right? It'd be silly not to look at it that way. So can hospitals and surgeons drive process or care innovation? And I believe they can. Okay. And I think there's 3 vehicles to do that. And these are the vehicles that I think that we can work together. So one is bundles. Touch on this a little bit. Some of you are probably very familiar with this. Some of you may not be. Looking at pathway scrutiny, value in healthcare. Second is co-management, which is an interesting concept. I'll go over that. And then the last is a joint venture. So bundles and value-based purchasing, okay? We all utilize this concept in our daily lives. Probably never thought about this, okay? So you go down to the Piggly Wiggly and you buy an AC, right? And you want it to work well. You want it to last, right? You guys live in Virginia. I'm sure it gets hot as hell here in the summer. If it doesn't work, you want either A, your money back, or B, give me a new unit, okay? So that's how it works in, commercial, transactions that we do all the time. It was this guy, Michael Porter, who's a wonderful speaker. Why don't we do it in healthcare? Okay. And so he's influenced, and the payers are starting to think about this as well. Should there be value-based purchasing that relates to this? We've been involved with some of these bundles as it relates to some Fortune 500 companies. One of these companies came to us and said, here's our data. So in 2010, about a decade ago, they looked at 200 joint replacements that were done for their employees. So these are people that are working. And they were done at 38 different hospitals. The fee-for-service was all over the map. The pricing was all over the map. The outcomes were just as diverse. Some were good, some were horrible. And what they wanted is they wanted value, quality over cost. They wanted to pay one price, and they wanted a warranty for 60 days, which made a lot of sense. And this was perfect timing because around this time, there were these programs, the Bundle Payment for Care Improvement, or AKA BPCI program. Looking at these 90-day episodes. And if you started to add up all the dollars in terms of this, this was a lot of money on a per case basis. And notice about 40% of the bundle was post-acute care. Okay. So I think everyone got on board with this and looked at, was there opportunities? We got involved with this. There were different models. We were in this retrospective model where there was a target price. It was a fee for service. We added up all the bills. We hired a convener to basically look at the data and run the data management. The surgeon's role is basically, at the time, just keep doing what you're doing, except we want you to decrease implant price. Always a dicey proposition. Decrease length of stay, avoid rehab. Don't let them go to skilled nursing facility. Whatever you do, don't let your patients go to the emergency room, and call patients every week to make sure they're okay. So other than that, just keep doing what you're doing, okay? So that's a lot. That's a big ask right here, okay? So, here's our early experience. It was not good. Okay. The convener was too expensive. CMS moved the goalposts. They changed the target price. They want to be a money loser. And what we really did, when we looked at our data, we were not doing well on patients going to rehab, readmits, and high-risk patients. It just didn't have a good plan. The CJR program, which then succeeded the BPCI program, was a big change for us. The target price was a year 1 through year 3, a historic blend of what we were doing and what was being done in the region. And there were a couple of, I would say, metropolitan hospitals that were part of our region that were really doing a terrible job. So there was a lot of opportunity for us as an organization. We still needed a convener, but we went to a low fixed rate. We're just going to pay you this, do your data management. But then we started getting a little bit smarter as it relates to case managers, nurse practitioners, development of home and rehab pathways. And what we projected is if we were in this program for about 5 years, we might be able to actually gain from the program about $4 million. So we sort of embraced that. We thought that there was a lot of money. So how do you make it work? We needed to do a lot of things. Number one, we needed to understand what our production costs were. So we started to price that out. So what does every single thing do? What does a phone call cost? What does a visit cost? Patient comes to the operating room. What are you doing? We recognize that readmissions are going to kill you. But we also recognize the surgeons need to drive this. We can't have hospital administrators. What were we prescribing? We're doing a lot of CT scans and for navigation and robotics, wide variety of implant costs. Sometimes same knee system could vary as much as $1,000. And then post-operatively decreasing rehab, skilled nursing facility, things like that. And 5 years ago, this is what, for example, if you send a patient to rehab, they just charge, it was flat rate, whether they stayed a day or a month, it was $7 grand. It's a lot of money, a lot of money. If they went to a skilled nursing facility, they got paid $700 a day. They loved the patients staying there as long as possible. And once they were out of your control, they were literally out of your control. So it was great. They just kept milking it and they would stay there forever. And then these home programs were not cheap, $4,500. So it was a lot of money on the table. So we started tracking individual costs, like episode of care, discharge, location, implant costs, all of this stuff. I'm starting to get a report card. So I'm going to share with you some of my own data. This is the kind of report cards that we would get, okay? So this is example. This is from several years ago, but it showed, for example, what my average cost for the episode was, what the average cost of the institution was, whether I was above. And so we would send these out quarterly to everyone. This is, implant pricing, what implant you're using, what does it cost compared to your colleagues, what are they doing? So we started looking at all this information. What were the patients? Where were they going? Blue was home. Pink was the skilled nursing facility, inpatient rehab in green. So you would get this quarterly report, actually, what's going on with your patients. If they went to a skilled nursing facility, this is what your average length of stay was, okay? And this is what the cost was. So you get these report cards, so you know exactly what was going on. These are your readmissions. The aggregate group on the left, my own personal scorecard on the right, okay? It tells you the number of readmissions. Now, the interesting thing is that whenever I think of readmission, I always think of, it's a hip or a knee. It's always related to that. No, it's anything. So the patient gets readmitted for an arrhythmia. Okay, that goes on your scorecard. Okay, that's part of your cost. So all of these things you wind up taking into account. They feel a little woozy. They go to the emergency room. They're found to be slightly anemic. They get a transfusion. They're admitted for a couple of days. Okay, that goes on your scorecard. That costs you money. So here's what we learned. A lot of things happen once the patient leaves the hospital, and without direction and instruction, other interested parties started to take over. Okay, other interested parties. So I think in the innovation of aftercare, preoperative risk assessment became crucial, after discharge planning, post-op monitoring, and then virtual PT. So we have a very robust NP program. All patients are called 2 days to 3 days after discharge. How you doing? Okay, what's going on? Pain, ambulation, how's the wound? Are you eating? Are you urinating? Everything okay? I think simple reduction in length of stay, I don't think that's a great metric, but reduction in discharge to extra care, either acute rehab or skilled nursing facilities is important. We develop pathways to our partners in both rehab and skilled nursing facility. We say, if we happen to have a patient that goes there, okay, this is what they need to do while they're there, and this is the maximum length of stay. And they want our business. So on those occasional patients that we send, we've seen a dramatic reduction in the number of ER visits with this post-op call program. It's been super effective. We actually summarized this. I wrote this up with our chief value officer, Kathy McLean, and published this 2 years ago in the New England Journal of Medicine. Here's the money slide. Okay. Remember I told you, I thought during the course of the program that in aggregate, we might be able to save and actually make $4 million. Look at the number here, $30 million. We killed it. We absolutely killed it. It was great. So we rolled back money to the doctors. We rolled up a lot of money to the hospital. The money that came back to the hospital helped support the program. We were the poster child. I got interviewed by some people from CMS. They were so excited. And you know what they did? They kicked us out of the program. Thank you very much. So we were so successful. The government thought we were making too much money. Said, you guys are doing something wrong. We said, we're not doing anything wrong, doing everything right. But the important part of this is that, yeah, so we're disappointed that we get kicked out of the program. We're not getting the money from, CMS anymore. But we've now continued to use this as a baseline for now as we're approaching bundles and value-based care, because this is going to be the future. And the reality is that there's going to be risk assumption that we're all going to take. This fee-for-service, the way that we're currently doing things, is probably going to go away at some point in time. You have to deeply understand your production costs. I think that's the important thing, and accountability on all parts. And I'm confident if done right, it can be a net positive for both the hospital as well as all of the individual surgeons and members of the team. And you can do this in joint replacement. You can do the spine surgery. You can probably do it in all of the disciplines in orthopedics. So I think it's extremely valuable. And I encourage you and the orthopedic team to strongly look at, if you're not doing this already, production costs and the concept of value-based care. Part and parcel of this is vehicle number 2, and that's co-management. A little bit of background, again, hospitals have been pretty savvy. Used to tell us, please reduce length of stay, reduce implant costs, don't send your patients to rehab, you can go home, all of that sort of stuff. What do we get out of this? More phone calls, more aggravation, more meetings, and all of this other stuff. The hospital was doing a good job of managing their costs, but the doctors were, I would say, maybe not getting their fair shake right in here. So was there a way to remedy this? And that is a concept of co-management and service line management. So this is a contractual arrangement between physicians and the hospital. It may take a different form for fully employed people in an academic setting, or maybe not, recognized both as a legal and regulatory viewpoint. So this is perfectly above board. Each entity recognizes the value that is a symbiotic relationship. There's lots of guardrails, though. Anytime an organization is giving money to physicians, it raises lots of red flags. The joint replacement service is the largest inpatient service at HSS. It's a critical component to current and future financial success. But it is a co-management, is definitely a vehicle. And it's an investment. And I would argue to administrators in your medical staff, making the institution the world-class organization that it is, such as UVA, and allows your surgeons to share in some of the financial benefits right there. It's got to be focused on patient and improving care with reductions of costs, obviously. It's got to be evidence-based and driven. It's got to be transparent. The goals need to be reasonable and appropriate, and compensation needs to be fair market value. So step 1 is identify what are the issues, what are the metrics, and the metrics fall into 3 buckets: quality, process, and program development. So quality measures might be surgical site infection, readmission, reoperations, those kinds of things. Again, applicable joint replacement, spine, actually any discipline. And then you can think outside the box. What are the other quality, modifiable risk factors? Do you institute a program that looks at, weight reduction, management of your diabetic patients, and things like that? So things that reflect that you reflects improvements in quality care. Process or efficiency measures, turnover times, on pathway rates, those types of things are something that are also definable measures. And then more granular aspects, you have to have a baseline. What's your goal? Is it aligned with the overarching goal for improvement in patient care? And then finally, what's it worth, right? Is it paid on an hourly basis? Is it a percentage of service line income? And what are the values in each of the metrics? This is where it gets a little sticky. So who determines this? So she does. It's Jennifer Johnson. Nobody knows who she is, right? So she works for a little organization called VMG. They're based in Dallas. They are like the 800, like Epic is to electronic health records, VMG is to doing these kinds of co-management stuff. So Jennifer and I became very good friends, arguing over the value of different metrics as it relates to co-management and things like that. And, it was always a negotiation. I'd start at 100, she started at $1, and we'd get somewhere between the two. More often than not, it was closer to $1 than 100. But anyway, that's the way it worked. So this is an example of our co-management metric baseline. So readmissions, complication rates, I won't go down the list, but this is what we look, we establish a baseline, and then we look at different tiers. You know, if you meet these metrics at these different levels, then this is what you get. This is a scorecard that we get. We look at this particular data. If you're not hitting your metrics, it's in red. That means you're not getting money for this stuff, which is important. So this always gets everyone's attention at our monthly business meeting at the Joint Replacement Service. Infection rate concern in terms of innovation. So this is a process improvement right in here. We were concerned, and I'm sure that most organizations, that infection prevention strategy is really, really important. This was a resident-run product right here. The residents brought to our attention, they didn't understand why we're still using betadine as a non-alcohol-based prep, because it was years of tradition. We've always used betadine. Why would we ever change, right? Not that there was any data. There was lots of data. Not that there was any data that we were looking at or reading about right there. So it was the residents that actually convinced us to go to chlorhexidine. So it was perfect. We were able to actually use this as a definable metric. So you can see in 2020, fourth quarter, 2/3 of the group were using alcohol-based antiseptics. All of a sudden we said, hey, if you switch over and we get enough of the group to do it, we'll actually get some money for co-management. The next thing you know, we're at 94. Now we're up to 98% compliance with alcohol-based antiseptics. It's had some small effect on surgical site infection rate. Tough to measure, multifactorial, as you're aware, but money works. There was no question. So lessons learned from co-management is a great bonding opportunity as members of the team. It's a team result. All individual data is included, but paid out as a team, which is good. So group dynamics, and there's clearly rewards for innovation, delivery of healthcare. And so I think that is the second important vehicle that you should consider. So again, bundles, value-based care is one, co-management is the second. And then the third, just for consideration, and there are sometimes some legal barriers to this, but something to consider for the group and maybe many of the faculty right here, are through joint ventures, innovation. So the tension at most academic centers is that, surgeons and staff come up with some idea. Question is, who owns it? And very often it's a lot easier, rather than work within the institution, go direct to industry. And that's been, I think, the playbook for a number of years. I don't know how much longer that's going to be effective. And I would argue that maybe within your own center, there's opportunities. We're always under the pressure of royalty policies. I'm sure UVA probably has a pretty rigorous royalty policy here. Maybe they do, maybe they don't. They do at HSS. Are they relevant? Are they enforceable? Why do I even need to give anything to the hospital? Food for thought. So my proposal is to resolve some of those innovation challenges, and I've been doing this at HSS. So we developed a joint venture. We called it HS Squared. So it's the power of the hospital for special surgery and the physicians is a joint venture. It's a holding company between the hospital and the members of the medical staff and professional staff. We're shareholders. We formed a limited liability corporation. We put a value on it. We had a capital raise. And the purpose was to develop and incubate organic in-house ideas and bring them to market, invest in external ventures as well. But it's more of an internal, I would say, incubator design right here. I'll give you a couple of examples right here. And not everything, but these are well underway. So this is some work that I did. I think I talked about it before. Look at the range of total knee costs right here. So for an implant system, again, femoral component, tibial component, patella button, piece of plastic, $2,200 to $3,800. That's a big range. Okay, and we do 7,000 knee replacements a year. That's a wide variability. Well, is one better than the other? So we reported on this. We couldn't find any difference. So at the end, they're all condylar implants, and then quite frankly, they all work. Okay, and there's no difference. And yet the price was obviously all over the map right in there. So I asked him, right, who runs our biomechanics, how much does it cost to make a knee replacement? About $500, $700. So why do they charge almost $4,000? There's lots of reasons. Number one, you can. Okay, so the margins are great. Okay, yeah, there's some development costs, but not a lot. It's distribution network and all this other jazz. So 30 years ago, we actually used to make implants in the basement at HSS. Kind of got out of that business because some regulatory issues and things like that. So we thought, maybe we start making our own implants again. So this is some work that we're working on at this point. Again, it's a condylar knee replacement. It looks absolutely no different from any other knee replacement that's out there. This is the design team right here. We've got the drawings. We actually have a partner that's looking and getting ready to do this. It's interesting. Many of the people that are in this picture, as well as others, they're interested. They will use this, if you want to call it evidence-based implant, at our upcoming ASC where they're equity owners, because the cost of this implant is going to be under $1,000. But in the main hospital, they still want to use their favorite implant. Anyway, that's life. That's the world that I live in right here. But anyway, so it's exciting about this opportunity. So that's one opportunity. The second is digital connectivity. So again, this is another in-house thing that we came up with. We learned a lot from the pandemic, right? I don't know if you guys remember what this was like. Right. Yeah. So those of you who didn't have the luxury of, that's what Zoom calls during the pandemic were like. It was just, it was tragic. I mean, it was just, I don't know what to say. So we thought that there's got to be a better way, and using digital platforms right here. So connectivity to patients, requiring a new approach, maximizing efficiency for the providers, and ease of experience for the consumer, in this case, the patient right here. So this is a company that we developed internally called UVA. It's web-based, no apps are needed, preloaded exams. There's an AI-driven algorithm where on the video, if you take a patient goes through a range of motion. It actually analyzes that and tells you what their real-time range of motion. So thoracic motion, shoulder motion, all of that. It also facilitates coding and billing. It expedites patient evaluation, ease of use for providers. It's still in its early stage. It'll probably go bust. I guess I'm somewhat of a shareholder in the venture, but it's exciting. Andy Roddick is one of the co-founders, the tennis player. He was involved in this, but it's an investment by our department and in our venture arm, and I think it's exciting, and I think it really has the ability and potential opportunity. But again, this is in-house, and it could be something that, again, it's good for patient care. And it probably could be an alternative revenue source, not only for the institution, but also for some of the providers. And then the last thing I'll touch on real quick is this is pretty exciting. Recovery from injury. This is something called Tesla suit. It has nothing to do with Elon Musk. He's not involved with this Tesla suit. So we talked about haptics as it relates to robots right here. So haptics has been expanding. Think Mako, but beyond surgical delivery, could there be a role of haptics in rehabilitation? So that is a haptic suit that you just saw. So recovery after orthopedics can be challenging. If you think about rehab, what do you do? How do you do it? When do you do it? And all of this other stuff. These Tesla suits are haptically programmed exercise and rehab, can be tailored to certain planes of motion, as well as the level of resistance. It's like uber cool, I can tell you right now. So especially for the guys in the sports division, using, especially shoulder motion and things like that. It was developed in collaboration with our motion analysis lab, Department of Physiatry, and our sports medicine docs right here. It's really exciting. I think the other application, and I think it's probably going to be the real potential moneymaker if this thing winds up working, is this gaming, right? So that's the big thing where they want to roll this thing out. Okay. And as well as, sports. Again, I confess that I'm a golfer right here. It actually can keep you on playing better when you're making practice golf swings and stuff. So it's pretty exciting. It's still novel. Each one of these suits is about $18,000. So it's like, keep telling me, it's not, there's no insurance that pays for it. I mean, it was $18,000 to pay for one of these suits. So it's in its experimental thing, but I think the concept is interesting. And I think that the whole aspect of having the clinicians, the scientists, the folks that work at your academic medical center come together with ideas and brewing them internally and working internally, I think is super, super exciting. So in summary, I think hospital surgeon collaboration, I think there's a couple of vehicles that all academic medical centers should think about. I think about that partnership. My personal experience has been positive, certainly as it relates to value-based care, as it relates to co-management. The investment part, well, we'll see what happens, you know. And financial pressures on both parties, both the hospital and the surgeons, I think can foster a spirit of collaboration, leading to innovation solutions. I think the key is communication for sure. So I think being open-minded about this. So I think it's exciting. I think the future is not so bleak. I know the first couple of slides were probably depressing in terms of where healthcare is going, but I think there are opportunities, and these incredibly talented men and women that are in the audience here, they are the future, and they all think like this. So I think I am optimistic about the future being bright. So with that, that's my thought on collaboration, and be happy to take some questions.
Thanks, Doug. Questions? Yes. Well,
You know, why is it that we have to be at mission? And you kind of made mention, you know, yeah, we were leaving the why does it go against the score? That kind of never makes sense when you sit down analyzing the survey or doing the survey, and these people have this predictions before they saw it. So what is this? I mean, I guess that you operated on them 30 days ago. Why did that have to go against what I did when they?
So the unfortunate thing is that those are the rules. That's the problem. And that's where, you know, quite frankly, and this, one of the big concerns is that many of the patients that get readmitted for non-orthopedic problems, many of them are not surprises, right? Oftentimes it is an exacerbation of some underlying health condition. And the biggest concern when the federal government rolled out these programs was that people were going to cherry pick, right? They were not going to take care of people that had other comorbidities, and that was the big concern. But that is, that's the risk that you take. This is all about risk sharing. You know, it's all about risk sharing. So unfortunately, those are the rules in the way that they're written. So any readmission during that, 30-day period of time, unfortunately, goes against, you know, your scorecard, whether it's or directly related to orthopedic surgery or not. I know. Look, I showed you my soul. I showed you my readmissions, right? Arrhythmia, transfusion, UTIs, and stuff like that. It's one thing, it's a dislocation of periprosthetic fracture. I get that. But yeah, those were the killers. And it was the non-orthopedic admissions. Somebody gets readmitted, they have an arrhythmia, they want to get a cath or something like that. Goes on your score.
You talk a lot about collaboration and working together. You obviously, it takes a lot of work to do these programs and have them be successful. It takes a lot of engagement. I mean, you look at all the work that you guys had to do, constantly looking at your data, looking at ways to improve. We here briefly entered into a bundled care arrangement for total joints that was unsuccessful. And one of the reasons I think it was unsuccessful is that they denied us any sort of gain sharing, any sort of meaningful financial collaboration. You talk a lot about money, right? A lot of this involves engagement through financial needs. Everyone has to benefit financially. Can you talk about that? I mean, do you think it's possible to do something like bundles without any sort of gain sharing arrangement with the surgeons?
I would be skeptical in the absence of an incentive. I mean, it's great for mom, apple pie, and the Cavaliers, but I think at some point, we just need to recognize that there needs to be more incentive than that. I'm just being realist, and money talks. There's got to be something. Now, money comes in different forms. Sometimes it's money in your back pocket. Sometimes it's money in the form of money that comes into the department, for example. So, research assistants, paying for faculty travel, and things like that. And so we have an implant savings fund that is different from this. That's pretty simple. If we can cut back on prices, we share that over a 3-year period of time. That goes into a travel fund. So when the arthroscopy guys went from suture anchor A to B, and we're saving, $50 a pop, but 7,000 arthroscopy. So it was a lot of money that goes into their implant savings fund, which can be used for travel research related.
So presumably your hospital takes a cut of that.
They
do. You split it 50-50 with the hospital. They get 50, you get 50.
Year 1, it's 50-50. Year 2, it's 30-70. They get 70. And year 3, it's 80-20. and then goes away in at the end of 3 years, 7 3 years, 3 years. So 50, 30, 20.
Any questions at all? Yes.
Can you talk some about, like, I guess the conversations that like lead to that? I feel like a lot of times, at least like here, it's not a person that hears you say, oh, like it'd be great if we could do this, but the C-suite said no, so it was just like that. So I guess like kind of how those conversations went, sort of how you ended up being able to get them to agree to doing that.
Yeah, and I mean, I think part of it is just understanding. So why is the answer no? Now, maybe it is an institutional regulatory reason or something like that. Well run, and you know, this change state laws is not going to be easy, but it does involve, number one, understanding is there opportunity. Number one, is there a problem, right? You know, in AA, you know, there's 12-step program. What's the first question in the first step? You know, hi, my name is Bob, and I've got a problem. If you're in healthcare and you don't think there's an economic problem, you are in the wrong field. Okay, you are blind, deaf, and dumb. Okay, there's a huge problem right here, and if you don't see it coming, then you know, really, you're in the wrong business. So number one, recognize that there's a problem right here. So what can you do? What can you do? I mean, I think about it as a hospital. I would say, operating plan for years was to simply grow, okay, and just expand. And so we have 30-something people on the joint replacement service lines, 162 orthopedic surgeons in the department, okay, and we would just grow. And you know, it is just expansion of operating rooms, and that worked for a while. But it gets to a point where you can't just continue to move that way. It just doesn't make sense. You have to look at other opportunities. So number one, it costs a lot of money to do joint replacement surgery in a hospital. I get it. JD and I are talking about this. The hospital likes it when you do your joint replacements in the hospital because they get this variable increase in the amount of money that they get. But if you costed that out, I guarantee it is cheaper for you to do your joint replacements and more lucrative to do it in this building than it is in the main house. I would put money on it. I tell you right now. So number one is understanding a lot of that, and sometimes people are either reluctant to accept that or truly understand what the costs involved with that. I mean, most large medical centers are going to be centers for complicated surgery. I mean, I'm sure transplants, all that stuff in the orthopedic realm, it's going to be complicated joint replacement. You're not going to do that in the ASC. You're not going to do it as an outpatient. You know, implant some of the revision stuff. Everything else, simple spine, even like 1-2 level fusion, it's going to be in the outpatient. It's going to be so much more efficient, and it's going to be lucrative. And then it winds up becoming, or you're going to have these little Burger Kings all set up in the Charlottesville area. But that is, you know, that's our plan at this point in time. So in the New York metropolitan area, so we're decanting the simple joint replacement, simple spine to the burbs. It just makes a lot more sense. And so, and those are joint ventures. Okay. And I know that there should be an ability to do that. I'm sure there's something. I don't know the city regulations.
Yeah, it's a challenge. Great. Okay, great. I don't know if I've seen this many people here at 8:30, Doug. So that's a testament to your talks. They were excellent. I think we all really enjoyed them. Thank you again for joining us. We do have a little swag for you here. All right. So here we're proudly have t-shirt. Yeah, thank you. Yeah.